Good morning. I'm Phil Owen, a peer recovery coach for Communities for Recovery at the Targeted Response Team. This morning I have Dr. Matthew Jr. with Austin Addiction Medicine. Good morning, Dr. Masters.
Good morning, Phil. How are you?
I'm doing just fine. So glad to have you on the show today. Could you give us a little background about yourself?
Yes. I went to medical school in Houston. I trained in internal medicine. I did internal medicine from 1990 to 2007, and from 2007 up to the present moment, I've done addiction medicine. My clinic is here in Austin, Texas, and I have worked in inpatient rehab, and I have also been the medical director of a methadone clinic, and I have my own outpatient practice. I have done medical legal consulting with regard to addiction and addiction medicine. And right now I'm on the front lines dealing with the opioid overdose epidemic, mainly in the capacity of treating opioid addicts. However, my practice is 80% is either opioid dependence or alcoholism. The other 20%, about 10% of that is psychiatric issues, and 10% is other. And so that's my story. I'm sticking to it.
Great. Well, we certainly appreciate you for the work you do. You know, you have been a guest to the Austin area work group before. That's why I really wanted to have you on this show. Is the content that you bring? It's a bit cutting edge. It's factual, and I think it needs to be heard. You know, I like the we're addressing the epidemic during this whole COVID-19 pandemic. Frankly, I've heard a bit much about it, and I tend to believe that we're all suffering a little COVID-19 isolation fatigue. But the opioid epidemic has gone nowhere, which is why we're talking about it today.
Excellent. I totally agree with you. I feel like there has been quite a bit of hysteria regarding the COVID-19 epidemic, and that a lot of that has been fanned by the media. Now, I'm not trying to minimize the importance of coronavirus. I mean, obviously, if you live on the East Coast or the West Coast in areas of high population density, it's a very, very real problem. But when you apply the same strategy to the entire country, where prevalence rates are actually much lower, then I think what you do is you wind up crippling the economy by and large, and greatly constricting people's lives. And I think that at some point that's got to change. Coronavirus is here to stay, but it is not going to kill anywhere near the number of people that the opioid overdose epidemic will kill. Last year, we lost 72,000 people. In the 12 years that we were in Vietnam, from 1963 to 1975, we lost 58,000 soldiers. We have a Vietnam that occurs every year in this country owing to the opioid epidemic, the epidemic of opioid dependence and overdose. And we have communities that are virtually crippled by opioid overdose deaths. And those are much more important as a in terms of the number of deaths that they cause than coronavirus will be. So I've been working on the front lines now for quite some time, and I've seen this problem largely ignored by society. And it's largely ignored by society because of the stigma attached to opioid dependence. But when we look at the perpetrators of the opioid epidemic, we don't have far to look, because it's physicians and pharmaceutical companies, big pharma. It's no secret that Purdue Pharma marketed OxyContin, provided the medical profession with false data about the addictive nature of opioids, and that is what fueled the crisis. And it's sad to say, but there were certainly physicians who were nothing more than legal drug dealers who promoted this epidemic. And once the feds got wise to this and they turned down the faucet with respect to the supply of oral opioids, then we saw the epidemic shift from prescription drugs over into heroin. Now, for the past 6 or 7 years, up until recently, I had been medical director of a methadone clinic, so I was seeing an increasing influx of these very patients. And, you know, I think that the pain movement of the late 80s, early 90s is what gave rise to the overuse of opioids in medical practice and the imprudent use of opioids for the treatment of what I would refer to as pain arising from benign or non-cancerous conditions.
Right.
Certainly in the setting of a terminally ill cancer patient, the doctor should use opioids without worrying about getting the patient addicted. But when you are dealing with a chronic pain, there's no good data to indicate that opioids actually benefit that. And in many cases, they do harm. So right now, what we have in terms of our therapeutic armamentarium is 2 drugs, methadone and buprenorphine. Methadone is only available in a federally licensed, highly regulated methadone clinic. But buprenorphine, also known as Suboxone or Zubsolv, that medication can be written by practicing physicians in any specialty, so long as they have a special waiver from the DEA. And of course, I have one of those so-called X numbers that allows me to prescribe buprenorphine. Now, when it comes to opioid dependence, nothing is more efficient at getting the needle out of the arm or the pills out of the mouth than methadone or buprenorphine. I think one of the major tragedies that I witness on an ongoing basis is the continued insistence by the so-called sober community that we treat opioid dependence with 12-step recovery. Now, I would tell you that I am a huge proponent of 12-step recovery, and I also believe that 12-step recovery is very necessary in the treatment of opioid addicts, but it is a horrible strategy in the very beginning, because what you have to do in the treatment of opioid addicts is you have to interrupt the cycle of craving and dope sickness. And that's what buprenorphine and methadone are designed to do. They eliminate drug craving and they eliminate dope sickness. And then if I have you on the right dose and you shoot dope, you will not get high because your narcotic receptors are blocked. The problem with methadone and buprenorphine is that they don't do anything to address the underlying emotional, spiritual, mental reasons that you picked up opioids to begin with. For that, I really feel that you need a 12-step recovery program. But those of us in the profession and who have intimate firsthand knowledge of 12-step recovery, we know from experience that there is a very definite prejudice and bias against people who enter 12-step recovery and are on either methadone or buprenorphine. You know, the idea in 12-step recovery is sobriety, first, last, and always. And you know, the people in 12-step recovery, a large number of them, or a very high percentage, believe that the people who are taking methadone or buprenorphine are getting high from it. Now, if I'm giving you methadone or buprenorphine and you're taking it the way I direct, and you're not mixing it with anything harder than caffeine or nicotine, then you're sober, okay? You're not getting high from it. It just eliminates drug craving and it eliminates dope sickness. And so from my point of view, you are good to go as far as participating in 12-step recovery. But I can't tell you the number of times I have talked to patients that I was treating for opioid dependence who I had referred to 12-step recovery, who got a very frosty reception. And many of them will never go back because when they arrived in 12-step recovery, some knucklehead told them that they weren't sober, that they would need to give up methadone or they would need to give up buprenorphine if they wanted to get sober, quote unquote. Well, you know, I understand that point of view because I used to have that point of view. But it wasn't, you know, my exploring the scientific literature that changed my mind about how to treat opioid dependence. What changed my mind about having to treat opioid dependence was an addict who came into Texas Star Recovery when I was an attending physician there. Now, this young woman was a 25-year-old worker at Seton Hospital. She held down a full-time job and she was shooting 1 gram of heroin a day. And she came in and she said, "Oh, Dr. Masters, you know, I don't want methadone. I don't want buprenorphine. I just want you to use all of your medical expertise to help me detox. And then I'm going to work you know, a really strident 12-step program and recover." And man, I can't tell you, I was just totally down with that, you know, because doctors love tough people, you know, and this lady was tough. And so I told her, "Yes, ma'am, I'm on board. I'm going to do everything in my power to help you achieve your goal of sobriety and blah, blah, blah." And I mean, she was an inpatient there at Texas Star Recovery, so I could do everything up to and including benzodiazepines at night for sleep and for relief of anxiety. So I did everything at my disposal. And 48 hours later, She climbed a 14-foot high spiked iron rail fence. She went out and she shot heroin, but then she came back. Now, I'd had plenty of people who had left treatment. We call it eloping from treatment. I'd had plenty of people who eloped from treatment. They never came back. But this lady, she went out and she shot heroin, and then she came back because she really wanted to be off of heroin, you know? And at that point, I thought, you know, there is something else going on here. And I'm going to drop my own sobriety-based prejudices about this, and I'm going to treat this lady with Suboxone. And she left the hospital 5 days later and went on to do fine. Okay. So at that point, I began to look at the literature. And it was when I began to look at the literature that I really began to appreciate how severe the mortality statistics were associated with this epidemic. Okay. So if you are a frontline combat soldier in Vietnam, your chance of dying is 3% per year. Smoke a pack a day for 20 years, 1% per year. Alcoholic, 0.5% per year. Shoot dope, 7.2% per year. You are 2.5 times more likely to die from shooting heroin than you are from going to war. And that is why we have this huge population of people that is dying every day. And what do we hear about? Nothing but coronavirus. Coronavirus is a drop in the bucket compared to the people who are dying of the opioid overdose epidemic. And the funding for the treatment of the opioid overdose epidemic up until about 2016 or 2017, the funding for it was $450 million per year, okay, which is the cost of one F-35 fighter airplane, okay? And we were having at that time 52,000 deaths per year, which is 1,000 deaths per week. We don't have anywhere near 1,000 deaths per week due to coronavirus, okay? And this was over years. I mean, we're talking about almost 200,000 people who have died in this country of this epidemic, okay? Now listen, you get, you know, an epidemic of coronavirus and you shut down the entire economy and, you know, you force a lot of people into unemployment and poverty. And, you know, the number of people that are going to die pales in comparison to the number of people who have already died of this epidemic. So what's going on there? Well, it's stigma. And the only thing that broke that stigma was mothers of addicts who died, because those mothers started writing letters to Melania Trump. And Melania Trump pulled her husband aside and said, hey, look, I'm getting all these letters. And so that, you know, along with, you know, other legislators, got some bills passed so that some money, about $8 billion, got devoted to the treatment of this epidemic. But, you know, access to treatment is really quite limited. And the people who have the best access are the ones who have lots of money or they have insurance. And others are just sort of, you know, kind of catch as catch can. And so, you know, when I'm talking about the need to incorporate opioid dependent people within 12-step programs, I'm talking about a very real need, because 12-step programs are the cheapest form of recovery program, and for my money, the best that exists in American society today. So we want to be able to have those people access that very, very important form of treatment. But, if you've got people who are in the rooms who are telling you that, you can't get sober and you're not going to be sober because you're taking methadone or buprenorphine, that makes your situation hopeless. And it also alienates you even more than you are. And we both know that if you want to make any illness worse, all you have to do is isolate the patient. And people who, during this coronavirus epidemic, so-called normal people, they are getting a taste of what isolation is like. And many of them don't like it, okay? Because when you isolate someone, you can make any illness, whether it's emotional, spiritual, physical, or mental, you can make any of those illnesses worse. And that's what we're seeing. And I think that's the other thing that we're going to see on the other side of the coronavirus, is we're going to see a lot of relapses in the field of chemical dependency. And we're going to see a really drastic increase in the number of psychiatric illnesses that come to medical attention because of the degree of isolation that's been experienced. So in a nutshell, my mission really is to provide treatment for those affected by the disease of addiction, and to facilitate recovery wherever possible, and frankly to lobby on behalf of myself and others for increased access to resources to do so. And so that's why I do what I do.
Yeah, that's great. I'd like a couple of the things you said. First, to get a hold of funding for the underserved and indigent populations obviously have the least access to funding. The other part of that, I know as a person with lived experience, for me, treatment was fine and dandy. It got me out of my environment. But I think where the magic happened was when I was accepted into a recovery community and I was allowed to live in a sober living facility for years. I didn't want to be there, but eventually it became my normal. And I think that's what I needed to maintain recovery, to sustain it. Because when we talk about recovery, it's not just medication. It's not
right.
Get sober and move on. It is a lifelong approach to this. And, so I'm frightened mostly by this pandemic because of the people that are out there maintaining a habit, unable to stay distance because of maintaining that habit, no access to funding for treatment. Some treatment centers are even shutting down. Shelter, when you try to get shelter with a person with assisted treatment, if they're that fortunate, the housing doesn't accept them because that's not recovery in their book. There's a lot of barriers in place that make this a frightening system to navigate. And I know we talk about intent. What are your intentions? I know that a lot of people I work with, intentions vary from all the way white to all the way black and every shade of gray in between with what they want to do with their medication, their recovery, so on and so forth. It may be temporary. They may not be interested in being completely sober, and all those things are perfectly fine. I just want to see people become happy without pursuing our pleasure, spiking our dopamine in the pursuit of pleasure. I like to see people become happy, whatever that looks like for them. And you know, you've talked about the intent to abuse and this stuff before, and it really intrigues me because I see it on a daily basis. You know, another thing that frightens me from people not being able to social distance is Williamson County has just experienced a spike in overdoses due to home pressed pills that look like Xanax bars, the big white bars, and blue Oxycontin. Fortunately for the Oxycontin, have white flakes in them, so people are able to, if they're looking to tell the difference, they can tell them. But there's been a spike in overdoses, and so the cartels have not changed their business model during this. Only we have, and it just, if there is something to me, it's that we already have an ongoing epidemic, and that it's going to worsen, and access to treatment is going to worsen, and this sort of thing. So if there's anything in there that you'd like to speak to, please do.
Sure. Well, you know, I think you've touched on actually a gold mine in terms of the number and severity of the issues that we're dealing with on a daily basis. You know, access to treatment is marginal, particularly in the South and the Southwest down here in Texas. Now, you know, I've been to the ATOD conference, which is a conference that is organized by, you know, academia and clinicians who run methadone clinics. And you can see when you go there that there is a tremendous difference from state to state in the degree of access to treatment that people have. So in the Northeast, New England in particular, your access to treatment for opioid dependence is much better than it is here in Texas. You know, one of the problems that we have in addiction medicine is we have a problem enforcing or establishing a standard of care across the board. And I think of this as similar to what was happening earlier in American medicine around 1910. In 1910, we had the Flexner Report. And what the Flexner Report was it was a report commissioned by the federal government to establish standards for medical education throughout the country. And so at that time, Abraham Flexner went to visit Chicago, which had 14 medical schools at that time. And most of these were proprietary in nature. And the reason that he was mandated to come up with this report and standards were going to be enforced is because there were so many different types of forms of medical education, and people would run around calling themselves MD, but they didn't have a certain defined set of minimum standards of education. It could vary anywhere from someone who graduated from Johns Hopkins and was, you know, right at the top of their class to somebody who graduated from some for-profit podunk school in Chicago and was released on the publics and, you know, killed indiscriminately, if you will. So we don't have those kind of standards in addiction medicine, and that's what we really need right across the board. And I think that the federal government is where those kind of things come from. And right now, I think that the federal government needs to pressure the treatment facilities to stop treating everyone like they're an alcoholic and if they're an opioid addict, to treat them appropriately with methadone or buprenorphine and to maintain them on that. Now, when it comes to the idea of intent to abuse, that is a very real problem. And so what I would tell you is that as a medical director of a methadone clinic, my experience has been that 50% of the people coming to methadone treatment are still active drug addicts. They're just using methadone as a backstop until they can get more heroin, or they're combining methadone with other drugs to get a boost. The other 50% are in recovery, and they're evenly divided into 25% of the total will eventually wean completely off of methadone or buprenorphine. The other 25% of the total will take methadone or buprenorphine lifelong. They'll never do anything harder than caffeine or nicotine. They'll have kids, send kids to college, and lead average American lives. So, why is it that we as providers give methadone to everybody coming in the clinic? Because we don't know if you are in the 50% that's going to continue to abuse drugs, or you're in the 50% that's going to recover. And, a lot of times when I hear stories from people who are in sobriety-based recovery, those stories revolve around the losers, okay? They don't revolve around the winners. In other words, when you hear a story about how methadone or buprenorphine failed, it's always coming, that's the one that gets the most attention, But the successes, people don't see the successes because the successes aren't out there doing what addicts who are active in their disease do. So,
completely agree with that. The people I work with are often sent to me or referred to me because they struggle. And so we see the struggles. And oftentimes, they're in a mode of defending themselves because people stigmatize medication-assisted treatment as if they're still using. And I would believe it'd be safe to say that any medically managed medicine by a professional is always going to be safer than illicit drugs on the street. My son died at 22 by fentanyl overdose. He was sober prior to that. His mother really struggles with that mixed message. And I oftentimes, I struggled with it because I was gripping my sobriety very hard at the time. But the thing I do want to know is that there is a difference, that it's not always enabling use. Sometimes it's enabling life. We tend to think that had he been on a medically assisted program, rather than being completely sober at the time, had he a relapse, he may have survived it. We will never know, but I think it's important for parents and other people to know that, that medication-assisted treatment is not switching out one drug for another, and that it is a safer option.
Oh, very much so. Very much so.
We have to wrap things up. There's so much stuff I would like to expand on, and we could probably have a series together. But I want to leave you with one last question. I
Sure.
Put up your website so that people can find you. I'm going to do that again real quickly. But my last question for you is, if you were able to create your own flavor of ice cream, what would that flavor be?
Oh gosh. Gee, that's really a tough one because right now my favorite is salted caramel, which is a new flavor for me.
Right. Well, on this show, I always hit with the hardball questions at the end.
I think peanut butter and honey ice cream would be really great. Yeah.
Nice. Peanut butter.
I like peanut butter honey with graham crackers.
Yeah. Very good.
Okay.
Well, thank you so much, Dr. Matthew Masters Jr. Thank you so much for being on the show. Once again, everybody, please tune in. We've got a series of these running on the Communities for Recovery YouTube channel. Please subscribe to that and stay tuned for our next episode.